Hello. Welcome to our webinar on Managing Chronic Pain Naturally. My name is Tammy Bauman with Great Plains Quality Innovation Network, and I'm Quality Improvement Advisor on our Medication Safety and Care Coordination team. Great Plains QIN is the Quality Innovation Network, Quality Improvement Organization for Kansas, Nebraska, North Dakota, and South Dakota. We aim to achieve better health care, improved health, safer care, and lower health care costs. I'd like to welcome and thank our audience for participation today. We're fortunate enough to have representation from a diverse mix of partners and stakeholders from our four-state region. Today's webinar will be recorded and posted to our website at greatplainsquin.org. It will take about 3 to 5 business days to be able to access the recording. There will be an opportunity for questions after today's presentation, or you can post any questions via the chat function on the bottom right side of the screen. We will be monitoring the chat feature throughout today's WebEx session. Today's presentation, along with other upcoming webinars, focuses on treatment of pain, one of the 5 pillars to address the opioid epidemic at a community level. Previous webinars discussed take-back programs and prescription drug monitoring programs. Recordings of past webinars are available on the Great Plains QIN website. Now I'd like to introduce our speakers, Dr. Massey and Amy Reynoldson. Dr. John R. Massey is an anesthesiologist and pain management specialist in Lincoln, Nebraska. He graduated with honors from the University of Nebraska College of Medicine in 1990, and he has more than 28 years of diverse experiences, especially in pain management and anesthesiology. Amy Reynoldson is the Prescription Drug Overdose Prevention Coordinator with the Department of Health and Human Services, Division of Public Health. Amy oversees the implementation of the CDC Prescription Drug Overdose Prevention for States grants, which includes the Prescription Drug Monitoring Program, development and implementation of statewide prescribing guidance document for opioids, and naloxone education. We thank Dr. Massey and Amy for taking the time to present today and for sharing their knowledge and expertise with us. I will now turn the presentation over to them.
Hi, everyone. This is Amy Reynoldson. I'm excited to be a part of this webinar, and I do want to encourage any questions towards the end to help you guys with your state's prescribing guidelines. As Tammy said, I'm the Prescription Drug Overdose Prevention Coordinator with the Nebraska Department of Health and Human Services, Division of Public Health. My role is to oversee the implementation of our CDC Prevention for States grant, which includes 3 main strategies. But first, I'm going to go over the objectives of this webinar so everyone is all on the same page. We're going to discuss the development of the Nebraska Pain Guidance Task Force, describe the utilization of the CDC guidelines on opioids prescribing while developing the Nebraska Pain Guidance Document. We're also going to recognize the need to promote it as a grassroots effort to achieve that broad support. And then in summary, we'll share the key tools used in the Nebraska Pain Guidance Document. As I mentioned, I oversee the implementation of the CDC Prescription Drug Overdose Prevention for States grant. This is the grant that makes this possible for the state of Nebraska to do our focused prevention efforts on opioid prevention, as well as the development of this pain guidance document. This is a 4-year grant that was funded in September of 2015 and will end in August of 2019. The goals of the grant are to reduce the prescription drug overdoses, decrease the rates of opioid abuse, and also increase patient safety. We're going to be focusing on the second strategy of our PDO-PFS grant, which is the development and encouragement of the statewide uptake of the Nebraska Pain Management Guidance Document. And below that strategy, you'll see a direct web link to the Pain Guidance Document if anybody would like to click on that and pull up the document while I present. I'm going to first talk about how this document was developed. It was a rather large undertaking, so it's not something that happens overnight. When I started with the Department of Health and Human Services in March of 2016, there was already an internal DHHS group that had been meeting to discuss how to mobilize efforts to develop a pain guidance document. Those divisions that were included in this process were the Division of Behavioral Health, Division of Public Health, and Medicaid long-term care representatives. The discussions were focused on identifying what each division wanted to see in the document, how it would be utilized, and how we could develop one document that could serve all the needs of those three divisions. The three DHHS divisions identified potential challenges and barriers and problem-solved solutions to help keep the project mobilizing. It was identified early on that the approval process could be a challenge to navigate because this project was not included in legislation as a mandate or involved in rules and regulations. After inquiring with our legal department as well as the Division of Public Health Chief Medical Officer, it was determined that since this is a voluntary resource for our prescribers and dispensers to utilize, that the document should be presented to the applicable DHHS boards, which include the Board of Dentistry, Board of Medicine and Surgery, and the Board of Health, for input on the guidance document. Once input was received and any guidance was addressed or included in the document was then presented to the Division of Public Health Chief Medical Officer for final approval. Now I'm going to share some information about how we got to the format of the document. Before we started the writing process, the internal DHHS team researched what other states have been doing, specifically looking at their own state guidance documents. The group reviewed multiple national association and organizational guidelines as well to be inclusive of similar information. We wanted to make sure that we did not include information in our state guidance document that would be contradiction to what other national organizations were doing. The group reviewed Healthcare National Association and Organization guidance documents, and it included the Federation of State Medical Board guidelines for the chronic use of opioid analgesics, the ADA Resolution 64H 2016, the American Academy of Pain Medicine statements on the use of opioids for treatment of chronic pain, the American Academy of Family Physicians Pain Management and Opioid Abuse, CMS best practices for addressing prescription opioid overdoses, misuse, and addiction, the Agency Medical Directors Group Interagency Guideline on Prescribing Opioids for Pain, and also the CDC guidelines for treating chronic pain. After reviewing those organization or association guidelines, we started to look into what other states had been doing. We were able to pull 17 different state guidance documents to get an idea on how to organize content, what worked best, what wasn't working for those states who had those guidance documents developed, and also which guidance documents aligned with the ultimate goal or objective for the state of Nebraska with our pain management efforts, which was patient safety as the center of our model. The group was able to draw some conclusions when looking at the Oregon pain treatment guidelines as a template. The group felt that the organization of the content in this document was meaningful and easy to navigate. It also provided detailed information on specific demographic populations. Once the document was formatted, the internal DHHS team began to reach out to stakeholders to be part of the project and bring on subject matter experts such as Dr. Massey to the table. DHHS worked very closely with the Nebraska Medical Association and practicing clinicians that showed an interest in being part of this effort. The Pain Management Task Force was formed and began to meet monthly starting in December of 2016. The group was very supportive of using the Oregon document as a template and began to draft content that was specific to the Nebraska medicine practice. The group spent the next 8 months working on refining the content in the document to ensure that it aligned with current best practice standards. The Nebraska guidance document includes the CDC guidelines for treating chronic pain. The information is included to provide a foundation of the best practices when treating pain for patients with chronic pain. DHHS has also worked closely with stakeholders to implement the guidance document into the workflow with prescribers and their staff. Because the document is a voluntary resource for clinicians to utilize when treating patients, we have been focusing on operationalizing the document so it can be accessed in multiple contexts. The document is comprehensive and includes links to the Apple and Play Store so clinicians can access the CDC MME calculator when assessing the document via the website. Promoting the document has brought about several challenges. The Nebraska Pain Guidance Document, as I've mentioned, is voluntary. There is no mandate for prescribers to have to reference the document. So that definitely poses some issues in trying to get prescribers, dispensers, and their staff to utilize the document. When the Nebraska Guidance Document was finalized, all Nebraska licensed prescribers and dispensers received a link to the document via email. The document is also located on the Nebraska PDMP website, and we recently released a 1-hour education video to provide an overview of the pain guidance document, and it also includes free continuing ed hours for Nebraska licensed MDs, DOs, and dispensers. Operationalizing the document has been a work in progress. In November of 2017, we successfully connected the Nebraska Pain Guidance Document directly to the Nebraska PDMP through patient alerts. If an alert is displayed on a patient search, the PDMP user can access the pain guidance document by clicking on the alert information button that then provides details about that specific alert, as well as direct links to the pain guidance document, such as the section on MME calculations, tapering, or how to treat patients with acute pain. Promoting the document has also been a current focus. It's important to educate medical professionals about the document and get it in front of them. We have aligned our efforts with the Division of Behavioral Health and provided an outreach training to substance abuse prevention coalitions on the opioid prevention efforts that the Division of Public Health is implementing. This includes our PDMP, pain guidance, and naloxone education efforts. We educated the local community coalitions so that they could reach out to their local physicians, nurses, and pharmacists to educate them about the importance of utilizing the pain guidance document to provide consistent treatment for patients. Utilizing the local community members to mobilize this effort has been advantageous since they have an established relationship and are able to provide that continuous support. I am now going to turn it over to Dr. Massey and allow him the opportunity to share with you the physician's perspective.
Good afternoon, everybody. This is John Massey, as Amy said, and thanks for attending this. I wanted to talk about some of the clinical aspects of our work on the committee, how we came up with our strategies and our solutions, and what the rationale was for each of those. So let me see if I can move that ball for us. Can you shift that for me, Amy?
We shifted it, Dr. Massey. You should have control.
You got it. All right, thank you. So when we're looking at what our challenges were from a clinical perspective, we had to keep in mind that, clinicians don't set out to do a bad job for patients and expose patients to inappropriate prescribing. And that being said, patients don't set out to deceive clinicians and find themselves in a position where they're abusing medications or having risky behavior that can lead to overdose. So we wanted to look at the aspects of this problem from a clinical perspective and how we can make this document something that assists clinicians in making good choices. We knew that if we were heavy-handed and we said it's all about MMEs or when not to prescribe and what have you, it would probably not be taken in with the same amount of interest as if we provided a document that was able to overcome some of the barriers that clinicians have with respect to doing the right thing. In Nebraska, we have unique challenges, but certainly I'm sure many states have those. Naturally, the demographics of this situation are changing with an older population as we go forward. In Nebraska, we have a particular access to care issue, and that is treating chronic pain without medications of abuse is harder at points because clinicians don't have all the resources in their community, and that can be an access or a barrier issue for patients. And the other thing that is probably really important to understand is that some of the communication, the lack of education that clinicians have had in the past regarding pain, I think has been recognized by many people as inadequate. There are a few kind of sentinel events that I think most of us understand by now were very problematic in the development of the prescription opioid problem. We all know by now that pain is the fifth vital sign. In the late 90s was a big problem. The other thing that I think is probably a problem that we need to be upfront about recognizing is some of the influences of outside industries. And, one of the things that we think of is many times we're told pain is subjective, and there's a lot of information around that. But for the purposes of this document, we wanted to show to clinicians that it's not as subjective as we want this to be sometimes. And there's a lot of good work that can be done to objectify this problem and make clinicians have better choices with data. Clinicians are always very interested in data, and so our big task with the committee was to put enough people together that they could understand the data, that we could speak the same language and move forward in a way that everyone felt like they were speaking the same language. And why was that important? We understand that when we get to the opioid overdose epidemic, there's a widely increasing number of people who are fatally affected by these medications. But that's obviously the tip of the mountain. And if we can make identification earlier on in the problem, before people develop addiction or overdose risk, we find misuse and use, there's a continuum of this. When we understand the continuum and we understand the risk factors that take somebody from appropriate use to inappropriate use, and if we can use better data to identify the difference between appropriate use and inappropriate use, and have every clinician who is prescribing for their patients understand that data set, then we're going to move everybody to the left on this top of this, from problematic use into use that's appropriate. So when we did that, we needed to have a uniform set of data and a uniform set of tools. And also, we felt we needed a document that educated the clinicians about the why of the tools, when to use the tools, and how to apply these in a fashion that was consistent or uniform for all their patients. Why we wanted to do that is that helps clinicians be more consistent in their education and understanding, and more whole. So some of the tools that we put in the guidance document, of course, a pain agreement. What's the importance of the pain agreement? Of course, that's to explicitly explain to the patient the difference between appropriate and inappropriate use. Patients who develop problems with misuse and later addiction are developing these problems not because they're doing so volitionally, but really because they're losing control of the use of the medications. So the pain agreement's purpose, and we explain this in the document, is to show the difference between I'm in control of my medication to I'm not in control of my medication, and the types of behaviors that we see and how that applies to clinical decision-making regarding going forward. The data collection, there's different points in the management of a patient that we need to collect data. What kind of data we collect under different circumstances is delineated in our document, and we think it's a very helpful tool for patients and clinicians to use throughout the course. The idea of universal precautions is an important aspect, we believe, of the document, and that is to say that it's never fully possible to understand in advance what patients will develop problems in the long run. Therefore, what we want to be doing is applying the same principles and the same data to every set of patients. And as a clinician who prescribes, we want to indicate in the document that it's the responsibility of the prescriber in conjunction with the patient that's being prescribed these types of medications to start out initially with the process that's fully transparent and upfront, so that we can explain to the patient what we're doing to make sure that we're using these medications safely, and when they're not being used safely, what we're going to do to reduce the risk. We think that's a very important part of this, because a lot of the conversation gets off into a kind of a blame game, which of course is inappropriate with respect to the clinical discussion. We want to make sure that we're helping patients throughout the course of care, and we're doing so in a way that makes them safe and also keeps them comfortable. And of course, the other role of lab testing and so forth is explained in the document as well. One of the things that we're trying to educate clinicians with respect to the universal precautions are ways to expedite their day and organize their thinking regarding these patients with respect to not just data sets, but a program that they can use that shows when it's appropriate and when it's not appropriate for a patient to be getting these kinds of medications. So not only do we want to use metrics and measurements that take some time in the clinician's office to fill out on the part of the patient or the clinician, but also some shortcuts to help them think throughout their day that make them a little bit more likely to apply these principles because they're actually saving them time as well as improving the quality of their care. One of the things, for example, in our document is the 4 A's. This is something that we recommend in the document that is managed at every patient encounter with respect to the medications of abuse and whether it's something that's good for the patient or not. It has been shown to be clinically relevant. It's something that can be put in a note, can be put in an EMR, and can be followed by other clinical staff as well as with some education of the provider's office staff so that they can understand what kind of data points they need to be providing to the clinical team so that we're doing the best, most proper care. Analgesia, adverse effects, activity. That 3rd A, activity and functionality, is measured in many ways in our document, but it's been shown to be the one metric that we must continue to measure. Most of you probably know that when we measure activity levels in an individual who's developing risky behaviors and or worsening problems with medication misuse, we will see as an initial event, we'll see a decline in functionality or unexplained loss of functionality. That's really about the patient being affected by a comorbid disease of addiction and they're losing out on their ability to participate in their life. And many times, if the clinician identifies a loss of functionality that's unexplained, they can further look into the problem at an earlier stage and make appropriate changes in clinical care. And the last one, aberrant behaviors, we think is simply very important and probably something that needs to be included very directly in the document that is made in order to improve safety. What we see on a clinical basis, those of us who are in this area, are that patients who develop a problem with misuse, abuse, and later on addiction, they develop a set and an observable number of behaviors that are described as aberrant. That is, taking the medications in ways other than prescribed or in ways that show a loss of control over the use of those medications. That really becomes a sine qua non of abuse in the long run once those behaviors accumulate. Why that's important for us to specifically delineate in the document, why we really wanted to make this something educational for clinicians, is that when an individual is the provider, has the physician-patient relationship with the patient, they're in the best situation to earlier diagnose these aberrant behaviors and intervene effectively. And the sooner we intervene once an individual develops aberrant behaviors, the more likely we are to affect their care and to get them out of harm's way. So really going into how to identify aberrant use behaviors and what's important about that, we think was a really important clinical part of our document and something that's very important to us to have included. So some of the metrics that we use are really part of our effort with respect to the committee. One of the things that I'm most proud of is that our committee had a very wide variety of clinicians involved. We had pain specialists, we had ER docs, we had oncology, we had OB, we had family medicine, we had we had psychiatry, we had a large number of stakeholders who all have a little bit of a different understanding of the situation, but they all brought their own perspective. And then we were able to bring that perspective forward into the document so that any given specialist or any given primary care physician could understand that their particular situation was addressed within the chapters of the document. We think that that's really important. And the other thing that was really helpful then is we were able to come forward with a broad list of metrics that we can recommend in the document and that clinicians can use under the various circumstances when they're appropriate. We have a good appendix in our document that explains for example, when you would want to use a SOAP versus when you would want to use a DAST or an ORT, what the importance is of PHQ or screening for psychological comorbidities and what have you. This document is something that I think is going to need ongoing education. This part of the document, because these metrics oftentimes are seen by clinicians as a hamper with respect to getting through their day. Our point of view with respect to the committee is that they're just the opposite. They expedite care because they allow you to more quickly come to a good and solid clinical discussion and intervene appropriately for the patients when they need it or when there's a change in the metrics that would suggest a problem with the medication. And this last chapter, I think, is one that I would very much encourage people to pay attention to. And I think it's, at least in my belief, it's the most important chapter in our document, The Art of a Difficult Conversation. And the premise of the chapter is this. One of the things that we see as a major problem is that patients who are developing a problem with misuse of medications really oftentimes through no fault of their own end up in this doctor shopping mode or drug seeker mode where they're hopping from place to place, from clinician to clinician, who doesn't have the necessary information to get appropriate identification of a developing opioid or medication problem. The other thing that happens around this problem is that a clinician who has developed a challenging situation with a patient, they may be leveraged if they're prescribing for a patient because they don't know how to explain to the patient when it's not in their best interest, and they probably delay that because they're either ambivalent or concerned or worried that this might have some sort of a negative effect on the relationship with the patient or other family members. So what we really want people to take home in this document with respect to the art of a difficult conversation is that the initial prescribing physician is the one who is in the best position to make the identification of a problem and then to back the patient out of the problem. That is the person who is in the best position to get a patient away from these medications once they become problematic. We understand that clinicians feel that makes sense, but they just don't know how, they don't know when, and they don't know why. And our chapter with respect to how to back a patient out of that situation, I think, is probably something that in the long run, if we can get our providers in the state to take this in and really implement it in their practice, will do the most to save lives and to improve care. We went to really great lengths in the document to state that it's not appropriate to fire a patient once they develop a problem with medication use. If you've been participating in the problem from the start, you want to be the one who helps them get away from this. It's respectful of the patient's life. It's respectful of the patient's comorbid development of substance use disorder, and it's really something that helps them get back to a better lifestyle and what have you. So we're hopeful that this is something that's taken up in the future and really taken to heart by the people in the state of Nebraska who this document reaches. That's what I have in my. Let me pass this back here.
Great. Thank you very much. All right. We're going to use our remaining time here for questions for either speaker. Please enter your questions either in chat or you can ask via the phone. Use *6 to unmute yourself. And then after, please press *6 to remute your line. So while we're getting some of this, I have pass the ball again here. So questions. Jamie, do you have any questions in chat or coming up in the queue?
No questions yet. We had some comments about finding the tool very useful and interested in having a similar document within the state, within their state. A question that I had in listening to the presentation, and I really thank you for this presentation, it was excellent, was, you talked about the continuing education offered and stuff like that. I was wondering if you have ideas on how many individuals have completed that, or some of the impact that's been made with the document?
This is Amy Reynoldson. I can answer, and then Dr. Massey, feel free to chime in. I do not have the numbers of those that have completed the continuing education at this time. Our Nebraska Medical Association has been a great partner, and they're overseeing the CME process for all MDs and DOs, and I have not received an update from them yet on that process. We did just release the education mid to late February, so it's fairly new. And then I also want to make sure folks are aware, we will have some additional education components coming out that drill down deeper on 3 particular chapters of the document, and these came in as high requested areas to learn more about. And it's on the art of a difficult conversation, tapering both benzodiazepines as well as opioids, and then treating acute care or acute pain in multiple demographics of patients. So it talks about adolescents versus adults and so on. And those will be half-hour continuing ed opportunities that will be made available. We're anticipating in May, late May to early June. Those will be located on the same page as our current education opportunity on our PDMP website. As far as how the document's reached, I do know that there are some physicians and clinicians that have reached out to me to, ask for permission to utilize it, but we also have some post-secondary medical schools that have adopted the document and are including it in their curriculum. So go ahead, Dr. Massey.
I wanted to add that, just as my role as a clinician in pain practice in the state, I'm involved in a lot of CME activity with respect to pain and what have you, and the interest and really just hunger for this kind of education is great. It's going to be an easy sell to get clinicians to participate in CMEs regarding this document. As a matter of fact, I can't really go speak about any other subject in pain medicine throughout the state that this document and or the principles within this document don't come up. So I would say it's going to be an easy thing to get people to participate in once we give them all the tools that we're working on that provide CME credits.
Great. Thank you both. Jamie, have any questions come up?
Not yet. This is everyone's chance. Reminder to enter *6 to unmute your line if you want to ask a question over the phone.
I'm going to go ahead and talk a little bit until we hear someone come up. Just our continued discussion of the Nebraska Toolkit next month, focusing on its use as a provider and community resource. And the objectives of that include discussing how to use a pain guidance document in practice, review acute pain and chronic pain guidance, differentiate pain treatment recommendations related to patient populations, and identify other resources and considerations when developing a pain guidance document. And we invite you to visit the Great Plains website at greatplainsquin.org for resources pertaining to medication safety and opioids, as well as other initiatives being led by the Great Plains Quin. Also be sure to join our Learning in Action Network if you're not currently a member to receive notifications on future educational offerings provided by the Great Plains Quality Innovation Network, such as these medication safety LAN events.
Amy, I have a question.
Sure.
This is Dwayne Wilson. I'm a retired pharmacist, and I would like to ask a question of Dr. Massey, if I could.
Sure.
I have to apologize for not having read the pain management guidance document, and so this may all be the questions that I have may be addressed in that if I would have read that in advance. But do you have some way that you, like where you're shortening the time that you keep patients on the opiate and make changes to different medications to try to complete their pain management? do you have some way that you contact the patient at about the time each change is made, or are they supposed to come back in and see their provider?
Okay, so let me restate your question. Is there something in the document that gives recommendations regarding duration or shortening the duration of the use of opioids? And what do we suggest for follow-up of patients when we're in the tapering phase? Is that what you're getting at?
Yeah, that's what I would be talking about.
Absolutely. Yeah, no, that's absolutely in the document, and it's kind of in because in our recommendations, and we worked on this. We really described limitations on the use of, for example, medications for acute pain, unless there's something outlying. And, we described that it's probably appropriate for the medications to be used for the shortest period of time and the lowest effective dose. Many times, simple post-operative pain, something like 2 to 3 days, and typically not more than a week. Something like that is in the document in various phases, and interestingly enough, we got into a situation where the legislature was making some laws about the use of medications and recommending that, for example, pediatric patients not get medications, and they weren't even yet aware of our document, and some of our recommendations were even more strict and or even more abruptly recommending cessation of medications afterwards. So we think we were able to get medication, acute pain medication changes in prescribing that I think are going to be both clinically accepted and also backed by good data. And we also have, with respect to the second part of that question, tapering, we have a chapter in the document that describes ways and or strategies that clinicians can use to assist with tapering, what kind of timeline to use, what the different techniques are, what the different rationale for each approach is. And I think these are really, like Amy said, one of those areas that there's a lot of clinician interest because they know they want to do it, they know they want to know how to do it, but this is a document that provides that. So I guess the answer to your question is yes and yes.
Okay, thank you very much. I will try to read the document in the near future, and if I have any future questions, contact either Amy or yourself, if that's all right.
Perfect. Yeah, at any time. Thank you.
Thank you very much.
We have about 6 minutes left. Have any other questions come up in chat or any questions out there? All right. I know Jamie is putting some information in the chat. Our contact information is here. We ask all attendees to complete the evaluation form for today's event to offer us feedback and help us plan and coordinate future events. We want to ensure we're meeting the needs of our provider partners. Your input is very important. Please use the evaluation to provide us with feedback on the types of topics you want us to address through this upcoming series. The evaluation should appear when you exit today's webinar. Please feel free to contact Great Plains Quinn Medication Safety Leads with any questions. Thanks again for your participation today, and we hope you found the information valuable and applicable. And we thank Dr. Massey and Amy Reynoldson again for presenting, and hope you're able to register for the April 10th webinar. And I'll ask one more time, is anybody in the queue to ask any question?
Nope, I think we're good, Tammy.
All right. Then we will end this just a couple minutes early. Thank you, everyone.
Thanks, everybody.